From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Jim Douketis, Professor of Medicine at McMaster University in Ontario, Canada. Today we will be discussing a review article that Dr. Douketis recently co-authored titled Perioperative Management of Patients Taking Direct Oral Anticoagulants. Welcome, Jim.
Thank you very much, Kristin. It's a pleasure to be part of this JAMA podcast.
So before we start, I'd like to just mention that direct oral anticoagulants are often called DOACs, and we will be using this abbreviation throughout the podcast. So your article focuses on the perioperative management of patients taking DOACs, which is an important topic because clinicians need to make decisions about these medications to minimize the risk of perioperative bleeding and thromboembolism. To start off, I'd like to ask a few general questions about DOACs. Which DOAC medications are currently available, and can you talk about their mechanisms of action?
Sure. The DOACs have become the dominant anticoagulants used in everyday practice, and they encompass 4 agents. These are, in alphabetical order, apixaban, dabigatran, edoxaban, and rivaroxaban. And they are used widely for patients with atrial fibrillation to prevent stroke and for the prevention and treatment of venous thromboembolism.
And what is the elimination half-life of DOACs and their peak onset of action?
Having a knowledge of their pharmacokinetic properties is really important because many patients who are on DOACs will require a surgery or procedure. In fact, about 1 in 5 every year will need to consider interrupting the DOAC before the surgery or procedure. So what we need to know is that they're very different from other anticoagulants like warfarin, for example, or low molecular weight heparins. And they're different in that they have a relatively quick offset of action and a relatively quick onset of action. So in terms of the offset, they have a half-life of about 10 to 12 hours. So we want to have at least around a 4 to 5 half-life interval for many surgeries, especially high-risk surgeries. And then very importantly, Kristin, these agents act quickly when they're taken by mouth. So their peak onset of action is about 2 hours after you take them. And that's really important in a perioperative setting because if they act quickly, you don't want to subject patients to bleeding, especially at the surgical or procedure site.
Can you discuss the advantages of DOACs compared with the vitamin K antagonist warfarin?
There are 2 major advantages of the newer direct oral anticoagulants or DOACs over warfarin. The first one is that the DOACs appear to be safer, associated with less bleeding and in particular, less intracranial bleeding. The second advantage is a practical one in that with warfarin, we require laboratory monitoring with the INR or International Normalized Ratio test, which is a way of measuring the anticoagulant effect of warfarin. And typically the therapeutic range, as most people know, is 2 to 3. We don't need to do that with the DOACs because the dosing is standard for all patients and does not need to be adjusted. So it's a lot easier medication to give because you don't need blood testing routinely and dose adjustments.
And which patients should not be treated with DOACs?
That's a really important point, Kristin, because DOAC use is proliferating in a number of indications, but there are situations where we should avoid them altogether. What are these? These are patients who have any kind of mechanical heart valve, even one of the newer type of mechanical heart valves referred to as onyx valves, any patients who has atrial fibrillation and rheumatic heart disease. These are patients that should also receive a vitamin K antagonist like warfarin, and then rare circumstances like conditions referred to as the antiphospholipid antibody syndrome. These are all groups of patients that should be receiving a vitamin K antagonist, not a DOAC.
Great. Moving on to your review, to assess the risk of bleeding associated with perioperative DOAC use, your article differentiates between patients who are undergoing procedures that are considered minimal bleeding risk, low to moderate bleeding risk, and high risk of bleeding. Can you provide a few examples of common procedures in each of these categories?
Sure. And determining or estimating the bleeding risk of a procedure or surgery really anchors perioperative management for DOACs and for other anticoagulants. And why is it important? Because if, as you referred, there are patients who are having a minimal bleed risk procedure, this can include minor dental work like teeth cleaning or an uncomplicated dental extraction. It can include certain types of eye surgery, like a cataract operation, which is largely avascular, or minor skin procedures as well, like a biopsy. And in these circumstances, we generally do not need to interrupt the anticoagulant, in this case the DOAC. Of course, if the patient is having a high bleeding risk surgery, and these would include any kind of major orthopedic surgery, any kind of cardiac, intracranial, or spinal surgery, of course, we need to be really cautious about ensuring that the drug is interrupted with sufficient time so that there's little or no anticoagulant at the time of the surgery and allowing time after the surgery. And then the groups that are kind of in the middle, what we refer to as the low to moderate risk, is a wider kind of swath of interventions that may include things like cholecystectomy, inguinal hernia repair, or other procedures that are more invasive.
So patients who are treated with warfarin are typically treated with heparin bridging, which involves administration of a low molecular weight heparin medication before and after surgery while an anticoagulant is being held in order to minimize the time that patients are not fully anticoagulated in the perioperative period. Should patients taking DOACs typically be treated with heparin bridging?
In general, we advise that bridging therapy with a heparin not be used in patients who are receiving a DOAC and need the DOAC to be interrupted for an elective surgery or procedure. Why is that? Well, as we referred to earlier, Kristin, these are drugs that have a relatively rapid offset of action and a rapid onset of action. So it doesn't really make sense to add a bridging agent when you can simply stop the DOAC 1 or 2 days before the surgery and resume it 1 or 2 days after the surgery. And also, there is evidence that if you do administer a bridging agent like a heparin in patients who are taking a DOAC, that in fact increases their risk for bleeding and doesn't really affect their risk for clotting or stroke. So we generally advise against bridging in patients who are taking a DOAC and need an elective surgery.
And I want to go back. You discussed how to handle patients who have a minimum bleeding risk procedure, such as a dental procedure. What do you do for patients with the low to moderate risk procedures in terms of when should they typically stop and restart their DOAC medication?
Sure. Before I talk about them, I just want to briefly make a comment about patients having a minimal bleed risk procedure. So let's say somebody is going to their dentist's office to have cleaning or a tooth extraction, on a weekday at, 10 or 11 o'clock. What we do advise is that if they take their DOAC in the morning, let's say with breakfast, to skip that dose altogether, or if they take a once-a-day DOAC to maybe take it later in the evening. Why? Because the peak effect of that DOAC will coincide with the timing of the procedure. So we want to avoid that. So even though we indicate for minimal bleed risk procedures to not interrupt, it's okay to skip, let's say, one dose if they're taking it twice a day, and then just delay the single day dose until later that day to avoid that kind of peak effect around the time of the procedure. Now, if we're dealing with situations where we do need to interrupt the DOAC, then if they're having a procedure classified as low to moderate risk, so let's say, a lap chole or an inguinal hernia repair, we advise patients to be off the DOAC for 2 days. So let's say they're having their procedure on a Wednesday. They don't take their DOAC on the Tuesday and on the Wednesday. So 2 days off. Let's say, however, if they're having a high bleed risk surgery, let's say a hip or knee replacement, again on the Wednesday, then they skip 2 days before. So nothing on Monday, nothing on Tuesday, of course, nothing on Wednesday, the day of their procedure or surgery, and nothing on Thursday. So it's a total of 4 days off. So 2 days off if they're low, moderate bleed risk, 4 days off in total if they're high bleed risk.
That's very helpful. Can you also discuss perioperative DOAC management strategies for patients who are unable to resume oral medications early in the postoperative period? So if they've had abdominal surgery or they have a post-op ileus or gastroparesis.
Yes, and that circumstance may arise periodically, and if we can't readminister an oral medication such as a DOAC, and this period may be extended for, let's say, 2 to 3 days, then it is quite reasonable to supplement that patient with a different type of blood thinner. And in this case, it would be a low dose of a low molecular weight heparin. It's not technically referred to as bridging therapy, but it is important because most of these patients are also at increased risk for venous thrombosis. So we want to give them some kind of prophylaxis postoperatively until that, ileus resolves and they're able to take their DOAC. And remember, once they take that DOAC, you're going to be giving them a high dose, relatively speaking, and the effect will be present quite quickly within a couple of hours. So let's say somebody's having the surgery again on a Wednesday and they've got an ileus postoperatively. We can't resume things on the Thursday or Friday. Then we may give them a low molecular weight heparin for 2 to 3 days and then perhaps resume the DOAC on the Saturday or 3 days after the surgery.
Your article also discusses endoscopic procedures, which are generally considered low to moderate bleeding risk, but in some cases, such as removal of a large colonic polyp, can be considered a high bleeding risk. How should DOACs be handled for these patients?
And I think this raises an important point, Kristin, in that we can't, classify every procedure because within a procedure type, there's various subtypes. And then, of course, patients are different. So when we think about an endoscopy, we think, oh, that's pretty straightforward. And in some cases, we just need to stop the DOAC for 1 day before if they're low moderate risk. But there will arise circumstances where you have to individualized management. So let's say a patient is having a colonoscopy. It's not for routine screening for cancer, but they've had a history of polyps and you anticipate you may need to do a polypectomy possibly. In those circumstances, because a polyp resection is considered high bleed risk among endoscopic procedures, it is prudent to consider them as high bleed risk, hold the DOAC for 2 full days before the procedure and for 2 full days after. And if it's possible, and I think this is important, is to try to communicate with the proceduralist, in this case, the gastroenterologist. What did they find in there? They have a number of techniques that they can use now to minimize bleeding. So it's good to have that conversation or for them to be aware of your perioperative management plan. And there may need to be some adjustments accordingly.
So far, we've been discussing elective surgery or procedures. Now I'd like to move on to emergent, urgent, and semi-urgent surgery. How are these non-elective surgeries defined in terms of the number of hours within presentation that the surgery should be performed?
Dealing with a patient who is taking a DOAC and needs a more, let's say, urgent procedure, we can refer to it as non-elective, is really challenging. Happily, this is only occurring in a minority of cases, but there may be situations where a patient is on a DOAC and they come to medical attention because of an emergency procedure need. a ruptured aneurysm, for example, or a bleed in the brain. And one can sort of separate them kind of arbitrarily into three groups. If it's an emergency surgery, typically you want to have it done within 6 to 8 hours. If it's a semi-urgent surgery, maybe this can be like a hip replacement. You probably want to have it done within 24 hours. And then there are other procedures that can be done afterwards that can be delayed slightly depending on the clinical circumstances. The management of these patients who require non-elective surgery is really quite different. And we have to be wary that these patients are a lot sicker. Our data show that they are at higher risk for both bleeding and thromboembolism. And we really have to individualize management depending on the urgency of the procedure. And also, of course, we have to take into account, did the patient take their medication soon before their presentation? And should we be administering a reversal agent to neutralize the anticoagulant effect? Really, these circumstances require, I think, a multidisciplinary kind of approach involving not just the hematologist or whoever is in charge of the anticoagulant management, but of course the interventionalist or surgeon and even the anesthesiologist and the ER physician. It's quite a complex situation that is anchored on the urgency of the surgery, the timing of the last dose of the DOAC for the patient, and whether or not we need to administer an anticoagulant neutralizing or reversal agent.
What is the bleeding risk associated with emergent or urgent surgery in patients taking DOACs? And what about the risk of venous and arterial thromboembolism?
As we mentioned, these are really high-risk patients, so the risk for thromboembolism really varies depending on the studies, depending on the patients that are assessed, but can be kind of in the 5 to 10%, 15% ballpark, and then bleeding can even go as high as 20%, and these are potentially serious bleeding episodes. But they reflect the clinical milieu of the situation because, for example, somebody presenting with already a retroperitoneal bleed from a ruptured aneurysm, abdominal aortic aneurysm, or an intracranial bleed, they are already subjected to a serious bleeding environment. So they are really at high risk. The risk for thromboembolism reflects the fact that they may have hemodynamic instability, but also one sort of caveat is that sometimes there's a reluctance to resume the blood thinner, the anticoagulant, in these patients. And we have found that if that anticoagulant is eventually resumed when it's safe to do so, that will mitigate against the risk for thromboembolic complications.
And you mentioned DOAC-specific reversal agents. Can you discuss a little bit about that and how effective they are?
This is an area of ongoing research, and there are two reversal agents that are available for use in the United States and other countries. The first one is called idarucizumab, and this is only specific to dabigatran, which is one of the DOACs we mentioned at the beginning that's not as widely used. On the other hand, there is a newer neutralizing reversal agent called andexanet alpha, which is a neutralizing agent for the oral factor Xa inhibitor. So these are much more commonly used, like apixaban and rivaroxaban. Unfortunately, we don't have a lot of data with these reversal agents in patients who are having emergency surgery or urgent surgery, and they've been studied more in patients who have had bleeding. So we don't have a lot of data as to their effectiveness, and we have to look at the individual clinical circumstances. Also, they're quite expensive. For example, andexanet alpha can cost at least $10,000 for a treatment. And there are other reversal options, and I'm referring to prothrombin complex concentrates, which are a little bit less costly, but even here we don't have a lot of high quality data. So it's hard to answer your question because we know they neutralize the effect of the DOAC. We just don't know how well they affect the overall clinical outcome of patients in this perioperative setting.
Your article discusses a management approach that's based on whether medical centers can provide DOAC level testing. Can you discuss this testing? How frequently is it available? And at what DOAC level is it considered safe to proceed with surgery without using a DOAC reversal agent?
Well, I started off, Kristin, by saying how we don't routinely measure blood levels of these agents like we measure the INR in patients taking warfarin. So the test to measure a level, the anticoagulant or blood thinning effect of the DOAC, is not widely available. In fact, most clinical centers are not set up to measure these levels. If there is a center that might be available to do this, for example, a trauma center where they get a higher volume perhaps of patients, then the DOAC levels can be used to inform management. So although this is not universally accepted, a threshold level of 50 nanograms per ml for a DOAC level may be considered a safe threshold to obviate the need for a DOAC neutralizing agent and allow that patient to undergo surgery or, in some cases, even a spinal anesthetic. But this is also an area of ongoing research. And as I mentioned, one should not be relying on this test because it is not widely available. And if it is not, then one has to individualize the management and consider using a DOAC neutralizing agent.
So that leads to my next question, which is if patients are at a medical center where there is no DOAC testing available, when should a reversal agent be considered if the DOAC was taken less than 48 hours before surgery?
If a DOAC has been taken 48 hours before, or in some cases, we can't really be sure when the DOAC was taken because the patient may not be able to respond reliably or that information is not available, then there really isn't another way to determine if there's a residual blood level present of the DOAC. For example, using an INR test or a PDT test. So you are reliant on that DOAC level if you have it. If you don't, and you think that the last DOAC dose was within the last 24 to 48 hours, then it is sensible to assume that there is some residual DOAC level present. You want to neutralize it to allow that patient to proceed to surgery in the safest possible manner.
And for patients who are needing semi-urgent surgery, how should they be managed in this situation?
Well, for semi-urgent surgery, these are a variety of patients. For example, an elderly person who may have a fall and has fractured their hip or their femur. Here, it also depends on when the patient can go to surgery. Typically we'd want them to be operated on within about 24 hours after their presentation. And if we have knowledge that we can, as to when the last dose of the DOAC was taken, and if we can allow that time to be stretched a bit to, let's say, 36 or 48 hours, then that would obviate the need for a reversal or neutralizing agent. So it really depends heavily on the type of surgery, when one thinks the last dose of the DOAC was taken, and when the timing of the surgery is most appropriate for that patient.
Before closing, is there anything else that you'd like to mention that we haven't previously discussed?
DOACs are going to be used more and more in the future because they are an easier anticoagulant to use and their clinical indications are expanding. Our population is getting older and more patients that we see are taking these medications. So I think it's worthwhile for the clinician. And this is an area that affects a wide array of healthcare professionals. So I think the article that we have in JAMA provides a concise way to inform healthcare professionals of a variety of backgrounds about how to manage patients. The last thing we want is surgeries to be postponed or canceled because People were not aware of the effect of the DOAC and how they work, or they may have been perhaps some communication lapses between the healthcare team. So I would suggest that for folks to have a look at the article, and it's something that most likely, irrespective of the specialty or area that they're in, they're going to probably have to come across at some point.
Thank you so much for sharing your thoughts with us about this interesting and important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Jim Douketis about his recent review article titled Perioperative Management of Patients Taking Direct Oral Anticoagulants. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.